Filming 3, 2, 1. Good morning, this is Susanna and this is Chris. Susanna is a sports rehabilitation student in her first year at Salford. She fractured her ankle 5-6 weeks ago?
6.5.
6.5 weeks ago. Came out of Plaster 4 days ago. She had an Open Reduction Internal Fixation. This is Chris. Chris is one of my recent graduates who's now doing a PhD. Chris is going to go through the assessment of the ankle. Just wanted to check with you guys that you're okay with being filmed and the fact that this will be used for teaching purposes, and it will probably either go on Blackboard or YouTube.
Yep.
And I ain't going to pay you for it.
That's fine.
Fine, thank you.
Susanna, so would you mind telling us a little bit about how your problem first started?
I was playing football,
Okay.
outside game, and it was wet, the ground was wet, and somebody shoved me and my foot slipped.
Okay. How long ago was this?
6.5 weeks.
6.5 weeks. And you remember how your foot moved?
Yeah, it was all off at 90 degrees.
Okay. So that rotating there.
Yeah.
And at the time, I gather you felt some amount of pain.
I didn't feel numb, completely numb.
Okay. Any sort of cracking sensation, any popping sensation, anything
No,
like that?
it was like hanging on.
Oh, okay. So it was visibly disfigured?
Yeah.
Okay, so then you went straight to hospital after that?
Yeah.
And tell me a little bit about what they did with your hospital.
They relocated it.
Okay.
I had done it a bit, and they did the rest, and then they put it in a plaster cast,
Okay.
and then the next day had the internal fixation.
Okay. Did they tell you what it was that was broke?
Yeah, they told me it was a fibula and a syndesmosis, and a bit off the posterior malleolus.
Okay. What did they fix?
They just fixed the fibula. Fixation on the fibula with the belt and screws.
Okay, so that was 6.5 weeks ago. And when did you have the plaster removed?
Wednesday last week.
And how's it been since having it removed?
It's really tight, and obviously not as much movement as the other one.
Yep.
Not painful, just uncomfortable.
Okay. Are you able to walk normally?
Not without crutches.
Okay, so you're walking with crutches at the
Yeah.
moment. Okay, what happens if you don't use the crutches?
I just end up having a bit of a limp.
Yeah.
And it doesn't feel right.
Okay, and how long can you walk with the crutches for?
I haven't really tested it, but probably comfortably about 5 minutes. It starts to get swollen.
So problems at the moment are that it swells.
Yeah, swelling.
Any other problems?
Just the tightness of all the
Swelling,
Yeah.
limited movement,
Yeah.
any sort of pain in there?
No, not real pain.
What's the sensation like? You said at the time it went numb, how did that feel now?
No, it's fine, yeah. In the morning I get like pins and needles on the base of the base.
Okay. How long does that last for?
Just a few minutes to get going, it's fine.
So is it generally worse in the morning?
Yeah, still, yeah.
What's the swelling like first thing in the morning?
It's the best it is during the day, yeah.
Yeah, and then the swelling gets worse
Yeah.
throughout the day?
Yeah.
Okay, no problem. Okay, other than walking, is there any other factors that particularly aggravate the swelling or the
Just
stiffness?
having it down a lot.
Okay. And is there anything that you can do that eases them symptoms?
Somebody told me about a warm bucket and a cold bucket.
Yep.
And been doing that like 2 minutes in the warm, 1 minute in the cold, 15 minutes,
Yep.
3 times a day.
And does that help?
That helps, yeah. And then ice as well.
Yeah. No problem.
Having it up.
And do you have any other previous medical conditions?
I had a herniated disc when I was 18, but
Yeah.
it wasn't really affected.
No problem. So you have no history of things like epilepsy, no diabetes, no history of rheumatoid arthritis, any family history of cancer or anything like that in family? Any unexplained weight loss recently? No, but you generally feel well.
Yeah.
No long-term use of steroids, no heart conditions.
Yeah, I've got pulmonary stenosis. It's very mild.
And is that monitored?
Not anymore, they said they don't need to be. So, no.
Do you have any blood pressure issues?
No.
No lung problems?
No.
And do you take any medication for anything at all?
No.
And what do you do for a living?
Student.
A student. And what is it you study?
Sport rehab.
Okay. So generally you have to be on your feet as well?
Yeah.
And hobbies, you mentioned you did that playing football, again, that's
Yeah.
something you want to get back to?
Yeah.
Okay. Any other hobbies or anything?
Just fitness, bit of running.
Of course they're all limited at the moment.
Yeah.
So they're ideally what you want to get back
Yeah.
to? No problem. Okay, so what we'll do next is we'll have a look at the ankle itself and see how it functions. So you could follow a line straight towards the camera. This is the right foot. Then if we could get rid of the crutches. Yeah. So on observation of that right foot moving, we can see that heel's raising fairly early throughout the stance to toe off phase of the gait. From behind we can see like that the forefoot is slightly abducted compared to the left. Functional range of movement testing for the ankle dorsiflexion, which is called the knee to wall test. So what I want you to do is, if you can step this foot forward for me. Okay, bring this one back. This is the back one's the one we're going to test. What I want you to do is keep your heel flat on the floor, foot nice and straight, and I want you to dip that knee as far as you can towards that wall without raising the heel. Okay, so now what you can do in this position is you can use what is known as an inclinometer to actually measure the joint angles. So as long as you measure from the same point each time, it will be reliable. So what we will do is just go off the back of the calcaneus along the Achilles tendon, maintain the inclinometer there, and that'll give us a joint reading. Relax and come back up. Now we're going to switch legs and do it with the opposite foot. So again, take that knee to the wall as far as you can.
I'm going anywhere.
As far as we can?
Yeah.
Okay, and we'll again take a reading. So if you haven't got access to an inclinometer, what you can do is just measure the distance from the wall. So what we'd do for that would be is if you bring this foot just away from the wall slightly, so bring your toes around here. Again, keep that heel flat on the floor and take your knee as far as you can to touch the wall. Okay, so you can back off a little bit with the foot, just go a little bit further back. Again, dip that knee as far as you can. So you're going to have to go a little bit further forward here. So take the toes a little bit further forward, there we go. So that's probably our limit. So what we then do is measure the distance between the toes from the wall. So that gives us an objective measure for ankle dorsiflexion. Now is functional range of movement testing for the ankle dorsiflexion, which is called the knee to wall test. So what I want you to do is, if you can step this foot forward for me. Okay, bring this one back. This is the back one's the one we're going to test. What I want you to do is keep your heel flat on the floor, foot nice and straight, and I want you to dip that knee as far as you can towards that wall without raising the heel. Okay, so now what you can do in this position is you can use what is known as an inclinometer to actually measure the joint angles. So as long as you measure from the same point each time, it will be reliable. So what we will do is just go off the back of the calcaneus along the Achilles tendon, maintain the inclinometer there, and that'll give us a joint reading. And relax and come back up. Now we're going to switch legs and do it with the opposite foot. So again, take that knee to the wall as far as you can.
I'm going anywhere.
As far as we can?
Yeah.
Okay, and again we'll take a reading. So if you haven't got access to an inclinometer, what you can do is just measure the distance from the wall. So what we'd do for that would be is if you bring this foot just away from the wall slightly, so bring your toes around here. Again, keep that heel flat on the floor and take your knee as far as you can to touch the wall. Okay, so you can back off a little bit with the foot, just go a little bit further back. Again, dip that knee as far as you can. So you're going to have to go a little bit further forward here. So take your toes a little bit further forward, there we go. So that's probably our limit. So what we then do is measure the distance between the toes from the wall. So that gives us an objective measure for ankle dorsiflexion.
Okay, go.
Okay, so in this position what we can have a look for is active range of movement. So first we'll just get like a rough estimation before we actually measure that. So if you pull both your feet up for us, so we can see the dorsiflexion between the two. Slightly reduced on that right, massively reduced on that right. Again, if you plantar flex both your feet, so put your toes all the way down, again you see there's a marked reduction in plantar flexion. We will get an accurate measure of that in a few minutes. And relax. And if you can turn this foot inwards forward, thank you, and that one. So again, quite a big reduction of inversion on that right foot. And if we turn the feet outwards, so turn the feet out for me. Oh. So again, we're only really getting to neutral on that right side for eversion, whereas we are getting some active eversion on that left foot. Relax. Another thing what we'll check in this position is strength. So first thing we'll look at is ankle dorsiflexion. So if you can, check the good foot first. If you can pull that foot up as hard as you can for me. As hard as you can, and relax. Okay, then we check it against the right side, so again, pull that one up as hard as you can. And relax. So she's actually got some good dorsiflexion strength there. So if we take that into passive full dorsiflexion, we'll check the inner range strength of the dorsiflexors. Again, keep that foot there, don't let me pull it down. Relax, and we'll do the same on that one. Keep that foot there, don't let me pull it down. So again, there is good strength on both sides. Slight reduction, so we'll be looking at about 4 out of 5 on an Oxford scale. So again, let's check plantar flexion. So if you can push that foot down as hard as you can. And relax. And again with this one, push that foot down as hard as you can. Relax one more time on that one. And again, one more time on that one. So again, when you're checking resisted plantar flexion using your hands, as you can kind of see, as she pushes down with that foot, she's actually able to push against all the force I can apply with my hand on both sides. That's why you get a far more accurate assessment by looking at a functional movement like a calf raise. So what next we'll check is strength of the everters. So if you push that foot out against my hand as hard as you can, and relax, and push this foot out as hard as you can. Okay, so we're looking at a slight reduction in everter strength, again about 4 out of 5. She is able to apply some resistance. Again, if you push that in to check the inverters. In to check the inverters on this side. So again, the ankle inverters are also quite marked and marked reduction in strength there. Okay, so what we're going to look at is the integrity of the Achilles tendon, so I'm going to do that using the Thompson test. Now we have just assessed active plantar flexion using a calf raise, so we clearly know that the Achilles is fully intact, but we'll do a Thompson test anyway. So, laying prone, calf relaxed, just going to apply pressure. As you can see, that foot is plantar flexing, and again on the left is also plantar flexing, so that's a negative Thompson test, which we knew was going to happen anyway because she can do a calf raise.
Smart ass. Okay, thanks for that, Chris. Could you talk through, first of all, Susanna, what you think your main problems are with this broken ankle, and then Chris, if you can tell me what your problems are as the physio.
So it just feels very tight, and I want to increase the range of motion a lot in it, so to be able to walk comfortably and eventually to be able to run and resume all the activities that I was doing. I'm really busy in the house a lot of the time, I've got kids, and I just want to be able to do all the things that I was doing with them before, all the sports, and driving is a big thing. I can't drive yet, it's not strong enough, so that's a short-term goal.
Okay. So as a physio, and from the assessment that we've just done, my three main problems with this would be the residual swelling, for one. That will also contribute to limiting the range of movement. So limited range of movement is going to be the second one. We haven't got enough plantar flexion or dorsiflexion there, so that's then having a knock-on effect on the gait and the muscle weakness and wastage around that area. So again, that will limit gait after a length of time. That's also limiting ability to run and put impact through that ankle joint. So my short-term goals would be, firstly, we need to restore that dorsiflexion, plantar flexion range of movement and reduce the swelling at the same time. So you break them down into two separate goals. So we'll reduce swelling, increase range of movement of all dorsiflexion, plantar flexion in an eversion, and then a long-term goal would be to improve muscle strength and muscle size of that ankle joint, particularly sort of the gastrocnemius and tibialis anterior.